Imagine you've got a patient trapped in a coma. I mean, the monitors are just blaring, the family is completely terrified, and down the hall, the MRI machine is broken.
It is a truly terrifying scenario, but, it happens more often than people think.
Yeah, it really does. And your only tool in that exact moment to figure out if their brainstem is still alive is to briskly twist their head from side to side. You're just checking to see if their eyes roll independently, like an antique porcelain doll.
Right. And in that moment, you aren't just looking for a broken bone on an X-ray. You are relying on a really profound understanding of microscopic chemical cascades and, well, invisible electrical signals to essentially save a life.
And that is the terrifying but honestly beautiful reality of clinical neurology. Because whether you are a medical student prepping for boards, a young professional on the wards, or just a fiercely curious self-taught learner, the human nervous system is arguably the most complex structure in the known universe.
Absolutely. And mastering its pathologies can feel incredibly daunting. It is the absolute definition of diagnostic muddy waters.
Muddy is a very good word for it, but it's also highly logical, right? Once you understand the underlying structural map of the brain and spine, the clinical presentation of pretty much any disease makes perfect sense.
It does. It really does.
And building that map is our mission for today's deep dive. We are jumping into a massive gold standard text for clinical neurology certification, which is the Mayo Clinic Neurology Board Review, Volume 2.
A fantastic resource.
Oh, it's incredibly dense. So we're going to synthesize this deep well of clinical criteria from critical care and cerebrovascular emergencies to movement disorders, electrical misfires, and even the ethical practice of medicine. We want to turn all these facts into practical, memorable knowledge for you.
And we will do that by focusing heavily on the mechanics. We won't just sit here and list symptoms. We're going to explore exactly why those symptoms manifest based on the actual neuroanatomy.
Right. And there is absolutely no better place to start than the very foundation of the nervous system, which is consciousness itself. Before we can even look for a specific neurological deficit, like, a weak arm or a vision problem, we have to establish if the patient's global network is even online.
Exactly. And clinically, consciousness is strictly defined as the combination of two distinct functions, which are awareness and arousal.
Okay, so break those down for us.
Well, arousal refers purely to wakefulness. It is the primitive brainstem-driven ability to just open your eyes and maintain a sleep-wake cycle.
Right.
Awareness, on the other hand, requires the higher cortex. It is the ability to assimilate content, to actually think, make decisions, and interact meaningfully with your environment.
I always like to think of it like a computer. So arousal is the hardware power, the fans are whirring, the screen is glowing. But awareness is the operating system actually loading and running programs. You can have the power surging through the machine, but if the operating system is corrupted, nobody is home.
That is a highly accurate analogy, actually. When a patient is in a true coma, meaning neither the power nor the operating system is functioning, the clinical evaluation becomes this high-stakes investigation of the brainstem.
Yeah.
And we do this through reflexes, like the oculocephalic response, which you mentioned earlier as the doll's eye reflex.
Okay, let's unpack this for a second.
Yeah.
Because if a patient is lying there completely unresponsive, paralyzed, and actively crashing, why are we wasting time twisting their head to check their eyes? Shouldn't we just be rushing them to the scanner?
Because you can't always wait for a scanner to decide your immediate interventions. The doll's eye reflex gives you an instant bedside differentiation. If you turn the head and the eyes automatically move in the opposite direction so they stay fixed on a single point in space, that means the brainstem's reflex arc is perfectly intact.
Wow, okay.
It proves the coma is supranuclear, meaning the shutdown is happening higher up in the cortex.
So you're essentially using their own anatomical reflexes as almost like a lie detector test for the brainstem. If the eyes move like a doll, the brainstem is structurally okay, and the coma might just be a metabolic issue like severe hypoglycemia or maybe a drug overdose.
Precisely. You might just need to push an antidote or correct their electrolytes rapidly. But if you turn the head and the eyes stay fixed in the sockets, moving with the head like painted on eyes, the brainstem is structurally compromised.
Oh, wow.
Yeah, in that case, you are likely dealing with a massive hemorrhage or herniation.
So it's all about speed and anatomical logic. Now, the text also goes really deep into motor posturing for comatose patients, these specific, rigid body movements they display in response to pain. So decorticate versus decerebrate posturing.
Right. The key anatomical landmark here is a structure in the midbrain called the red nucleus. It acts as this crucial checkpoint for motor signal.
Okay.
If physical damage occurs below the red nucleus, it severs specific nerve highways, namely the corticospinal and rubrospinal tracts. However, it leaves other primitive highways intact, like the pontine and medullary tracts in the lower brainstem.
And the imbalance of those surviving primitive tracts is what causes the body to twist into those specific shapes.
Yes, exactly. Damage below the red nucleus results in decerebrate posturing, where the arms rigidly extend and pronate outward. But if the lesion is higher up, above the red nucleus, the arms flex tightly inward over the chest. That is decorticate posturing.
Okay, but the source specifically mentions we shouldn't rely on the legs to localize this damage. Why are the legs, useless for this?
Well, in both decorticate and decerebrate posturing, the lower extremities do the exact same thing. They extend, basically straightening out with the toes pointed downward.
Ah, I see.
Because the legs react identically in both scenarios. Observing them tells you absolutely nothing about where the lesion is in relation to the red nucleus. You must look at the arms.
That makes total sense. So we've covered what happens when the global power goes out. But here's where it gets really interesting. What if the infrastructure itself starts breaking down in specific neighborhoods? This brings us to the plumbing issues, where blood flow stops, and the insulation failures, where the myelin sheath degrades.
Right, so the vascular plumbing issues are ischemic strokes.
Yeah.
The Mayo Clinic text really emphasizes localizing these based on very specific clinical presentations, particularly Lecuner syndromes.
And those are the tiny strokes in the deep brain structures, right?
Yeah. For instance, say a patient presents with a pure motor hemiparesis. One entire side of their face, arm, and leg is completely paralyzed, but they can feel a pinprick perfectly fine.
Wow. And the text localizes this to the internal capsule or the corona radiata. But what actually are those structures?
So the corona radiata is a massive fan-like crown of nerve fibers that descend from all over the outer cortex. As these fibers travel deeper into the brain, they funnel together into a very tight anatomical bottleneck called the internal capsule.
Like a funnel.
Exactly. And because all the motor fibers from the entire brain are squeezed through this one microscopic tunnel, a tiny blood clot blocking a single penetrating artery right there will paralyze the entire opposite side of the body.
It's just an incredible vulnerability in our design. Conversely, a pure sensory stroke, where movement is totally fine, but one side of the body goes completely numb, that localizes to the thalamus.
Because the thalamus is the brain's main sensory relay station. Every single piece of sensory data except smell actually routes through the thalamus before reaching your consciousness.
Now, the source also talks about a plumbing issue that isn't a clot, but a spasm. Reversible cerebrovascular vasoconstriction syndrome, or RCVS. And this presents with a thunderclap headache.
Right. A thunderclap headache is a pain that reaches maximum agonizing intensity within 60 seconds. Patients frequently describe it as the worst headache of their entire life. In RCVS, the blood vessels in the brain suddenly spasm and clamp down so violently that they restrict blood flow.
The triggers for this blew my mind, honestly. I mean, it can happen in the postpartum state, but it is also triggered by everyday vasoactive substances. We're talking about SSRI, antidepressants, cannabis, and sympathomimetics like pseudoephedrine.
Yes.
Like an over-the-counter cold medicine or a marijuana edible can cause the blood vessels to clamp down and trigger a maximum intensity headache.
It is a startling reality of neuropharmacology.
Okay.
These substances alter the vascular tone, leading to severe transient ischemia.
But wait, if I'm working in an ER and a patient screams they have the worst headache of their life, I'm immediately thinking they have a ruptured brain aneurysm, a deadly subarachnoid hemorrhage. How do we confidently distinguish this reversible RCVS from a massive brain bleed?
Well, you are absolutely right to assume the worst. You must always rule out the subarachnoid hemorrhage first with a CT scan and a lumbar puncture.
Okay, good.
If there is no blood in the brain or spinal fluid, you then look at the cerebral angiography, the imaging of the blood vessels. In RCVS, the angiogram shows a highly characteristic string of beads pattern.
String of beads.
Yeah, the vessels look like sausages because they are violently spasming in some areas and dilating in others. That imaging pattern, combined with the lack of hemorrhage, is what confirms RCVS.
Oh, that's fascinating. So that's a plumbing failure. What about the insulation? The demyelinating diseases? I feel like everyone knows the basics of multiple sclerosis, but the board review highlights this aggressive spectrum of inflammatory diseases that go way beyond standard MS.
It does. The text details variants that are incredibly severe. For example, the Marburg variant. While
Yeah.
typical MS might smolder for decades, Marburg is an acute, fulminant form that progresses wildly in a matter of weeks, destroying myelin very rapidly.
And then there is Balo concentric sclerosis.
Hmm.
The textbook describes this having a bizarre pathology where rings of demyelinated tissue alternate with rings of intact myelin. How does that even happen?
It represents a really fascinating microscopic battleground.
Hmm.
The immune system attacks the myelin in a wave, expanding outward from a central vein. But the tissue attempts to protect itself by expressing protective proteins, creating a ring of surviving myelin. Then the immune wave pushes further, creating alternating rings of destruction and preservation.
Oh, almost like the rings of a tree trunk.
Yes, exactly like that.
It's astounding that our own immune system creates these complex geographic patterns while actively destroying the brain. The text also mentions ADEM, acute disseminated encephalomyelitis.
ADEM usually follows a viral infection or a vaccination. The immune system just gets confused. It successfully fights off the virus, but molecular mimicry occurs. The proteins on the virus look very similar to the proteins on the patient's own myelin.
Oh, no.
Right. So the immune system turns around and launches a widespread acute attack on the brain and spinal cord's insulation.
So while strokes and acute demyelination happen fast, the brain also faces slow progressive threats. We are moving from the white matter tracts into the gray matter and the basal ganglia, the degenerating brain.
This is where we encounter the atypical Parkinsonian syndromes. Parkinson's disease itself is quite common, but the text focuses heavily on multiple system atrophy, or MSA.
Right.
MSA is a sporadic, adult-onset neurodegenerative disease. It doesn't just hit the dopamine centers like typical Parkinson's. It severely degrades the basal ganglia, the brainstem, the cerebellum, and the spinal cord simultaneously.
So what does this all mean? If standard Parkinson's is like a localized power steering fluid leak, making it hard to maneuver, MSA is basically a total catastrophic failure of the hardware. The engine block, the transmission, and the electrical alternator are all degrading at once.
That is a much more accurate framework. Because it attacks so many systems, half of all MSA patients present primarily with autonomic failure.
Their background automatic processes fail.
Exactly. They experience severe drops in blood pressure when they stand up, or a profound loss of bladder control. Another hallmark is prominent axial rigidity. Their trunk and neck become incredibly stiff, much more so than their arms or legs.
The source points out a highly specific statistic here. The mean age of onset for MSA is 53 years old. It's the youngest among the Parkinsonian syndromes. But why is it so crucial for a young medical professional to burn that specific number, 53, into their memory?
Because neurology is ultimately an exercise in clinical pattern recognition. If a 75-year-old patient comes in with a tremor and stiffness, you naturally suspect standard Parkinson's and start them on dopamine replacement.
Sure.
But if a 53-year-old walks into your clinic with a stiff neck and mentions they've been fainting every time they stand up, that combination drastically alters your differential diagnosis.
Oh.
MSA has a much faster decline and a much poorer prognosis. Identifying that hardware failure early changes the entire treatment plan.
That makes a lot of sense. And that structural degradation can also affect how we interact with the world physically. The text brings up limopraxia, defining it as the inability to perform simple motor tasks despite having absolutely no motor or sensory deficits.
Apraxia is a disconnect between the concept of a movement and the execution of that movement. The muscles are strong, the nerves feel everything perfectly, but the cortical planning area is degenerating.
Wow.
If you ask the patient to demonstrate how to use a key or brush their teeth, they simply cannot coordinate the sequence of actions.
A total failure of the highest level command centers, which naturally leads to cognitive dysfunction. The text draws a hard line between Alzheimer's disease, which is a progressive degenerative dementia, and non-degenerative encephalopathies.
This is a vital distinction for any clinician. Cognitive dysfunction means a failure of memory, language, or executive function without a change in consciousness. The patient is fully awake. Alzheimer's is a structural, permanent degeneration. But non-degenerative encephalopathies are often caused by toxic metabolic states, severe infections, or extreme vitamin deficiencies.
So if you assume an elderly patient just has Alzheimer's, but they actually have a severe metabolic imbalance, you are basically condemning them to a terrible fate when a simple IV could reverse their dementia completely.
Exactly the point. You must hunt for the reversible causes first.
Now let's trace these pathways further down. We've talked about structural degradation, but the text heavily emphasizes electrical storms, epilepsy.
Right. The board review strictly classifies seizures into two categories, which are provoked and unprovoked. A provoked seizure is a direct reaction to an acute insult, a sudden brain hemorrhage, a severe drop in blood sugar, or alcohol withdrawal. Correct the underlying temporary issue, and the seizures usually stop entirely.
And an unprovoked seizure means there's a permanent structural change, like, say, a microscopic scar from a stroke years ago that is chronically misfiring.
Yes.
When evaluating these electrical storms, I always imagine the brain as a massive, localized electrical grid. And the initial symptom a patient feels the aura is the first lightning strike. It tells you exactly which neighborhood the storm is originating from before it spreads.
The localizing value of those auras is profound. If the storm starts in the motor strip, you'll see contralateral limb movements or a Jacksonian march.
That's where the twitching spreads predictably up the arm, right? Because the electricity is literally moving sequentially across the motor homunculus.
Yes, the motor homunculus is the brain's distorted physical map of the human body laid out across the cortex. The area controlling the thumb sits right next to the area controlling the wrist, which sits next to the elbow. As the electrical misfire marches across that brain tissue, the physical twitching marches directly up the patient's arm.
It's an incredible visual. So if a patient tells me they suddenly feel a wave of pins and needles or electric shocks on one side of their body, that maps the lightning strike to the parietal lobe, where sensory input is processed.
Correct.
And what if they report seeing flashing lights or strange abstract shapes?
Well, the visual cortex resides in the occipital lobe at the very back of the brain. An electrical misfire there manifests as poorly formed visual hallucinations.
Okay, so those electrical signals eventually have to travel down into the spinal cord. And the text details a specific structural collapse caused by vitamin B12 deficiency. It causes subacute combined degeneration, specifically destroying the dorsal columns and the lateral corticospinal tracts. How does a simple vitamin deficiency destroy specific pillars of the spinal cord?
Vitamin B12 is crucial for the synthesis and maintenance of myelin. Without it, the longest and most heavily myelinated tracts in the spinal cord simply begin to unravel. The dorsal columns carry proprioception, your sense of where your body is in space, and vibration sense.
Okay.
And then the corticospinal tracts carry motor signals down to the legs.
So the patient develops profound sensory ataxia. They literally cannot feel where their feet are hitting the ground and their legs become spastic and weak. But why memorize these specific columns? Can't a doctor just order an MRI if someone's legs stop working?
An MRI might just show a vague bright spot on the spinal cord, but a thorough physical exam utilizing a tuning fork and a reflex hammer tells you the mechanism before the patient ever reaches the scanner. Yes. If you discover a loss of vibration sense combined with hyperactive reflexes, you suspect B12 deficiency instantly. You draw blood and order the vitamin replacement before the MRI is even scheduled. The neurological exam drives the clinical decision-making.
That is so powerful. But, all of this dense, incredible clinical knowledge from localizing the red nucleus to tracing B12 deficiency, it fails entirely without the framework of ethical application and flawless communication.
Absolutely. Medicine is not practiced in a textbook vacuum. The board review emphasizes the core principles of medical ethics expected since antiquity: autonomy, respecting a patient's right to control their own care; beneficence, acting strictly in the patient's best interest; non-maleficence, first, do no harm; justice, fair distribution of medical resources.
It also outlines disclosure, the foundation of informed consent, and the strict avoidance of conflicts of interest. But knowing the ethics isn't enough if the medical team cannot actually communicate critical details to each other. The text introduces the SBR framework: situation, background, assessment, recommendation.
It is a highly standardized method of verbal handoff. You state the immediate clinical situation, provide the relevant medical background, give your assessment of the problem, and make a clear recommendation for action.
And the reason this communication protocol is tested on a neurology board exam is staggering to me. The source cites a report from the Joint Commission stating that communication failure was the root cause of greater than 70% of sentinel events.
Yes.
A sentinel event is a patient death or serious permanent physical injury, over 70%. It's a jarring reminder that it's usually not a lack of anatomical knowledge that harms patients. It's a failure to pass that knowledge along to the next nurse or doctor on shift.
It is the most critical point of failure.
But wait, if I'm in an ICU, alarms are screaming, and a patient is actively herniating, doesn't forcing everyone to speak in a rigid SBR format just act as, bureaucratic red tape that slows down emergency interventions?
It actually does the exact opposite. Under extreme stress, human cognition narrows significantly and crucial details drop out of our working memory. SBR accelerates care by eliminating ambiguity.
Ah, I see.
When everyone speaks the same highly structured language, the listener knows exactly what information is coming and when. It ensures that critical data, like the fact that a patient just received a paralytic or has a severe medication allergy, is not lost in the panic.
To ensure those systems continuously improve, the text outlines a maintenance of certification process and the Planned Study Act, or PDSA, cycle. You don't just pass your boards and stop learning, you constantly audit your clinic's workflow to find the communication gaps and fix them.
Knowledge is only valuable when it is effectively applied to patient care.
Well said. Let's test how well you've applied today's knowledge with a quick review question right out of the spirit of this deep dive.
Sounds good.
So, you are evaluating a 53-year-old patient who presents with prominent axial rigidity and severe autonomic failure, such as fainting every time they stand up. Based on the structural hardware failures we discussed, what specific atypical Parkinsonian syndrome should be at the very top of your differential diagnosis?
Give it a thought.
If you remembered multiple system atrophy or MSA, you nailed it.
Recognizing that specific clinical pattern drastically alters the patient's prognosis and care plan.
It really does. Now, as we wrap up this deep dive, I want to leave you with a broader thought. We've spent this time mapping the brain's pathways, tracing the electrical grid, and categorizing structural diseases. But we are still standing on the edge of a massive frontier. The source material briefly touches on prion diseases, like Creutzfeldt-Jakob disease.
Yes, fascinating pathology.
Think about the mechanics of that. It's a single microscopic misfolded protein. It contains no DNA, no genetic material to replicate, yet it acts like a microscopic zombie. It bumps into healthy proteins and forces them to misfold as well. This cascade unravels decades of human memory, personality, and movement, and we still barely understand how to halt it.
It is deeply humbling. It reminds us that our models, homunculi, and textbooks, as profoundly detailed as they are just our best current approximations of biological reality.
Behind every lacunar stroke in the internal capsule, every focal seizure in the parietal lobe, and every SBR handoff at 3 a.m., there is a profound human mystery waiting to be better understood. When you first look at the nervous system, it might feel like looking at a broken machine full of muddy waters and invisible pathways. But the map is getting clearer every single day. Keep studying, keep questioning, and keep connecting the dots.